who will be sharing his insight and knowledge on this topic and how it is relevant for all of us today. And it is imperative that we stay updated about the latest trend and development in our respective fields. And this webinar provides a wonderful opportunity to do just that. So, I urge all of you to sit back, relax, and absorb the information that will be shared today. I promise it will be insightful and enriching our experience. And I hope by the end of this webinar, we will all have better understanding of today's topic. Ladies and gentlemen, allow me to introduce the today's agenda. First is opening by reciting Basmalah. Second, welcoming speech by Visden Medical Faculty of Mataram University, Dr. Rohadi, Neurosurgeon Neuro-Oncology Subspecialist Consultant. Third, lecture by Dr. Arif Juhan, Digestive Surgery of West Nusa Tenggara General Hospital. Fourth is guest lecture by Dr. Paul Gobardan, Medical Doctor PhD, on Gastrointestinal and Oncology Surgery of Ampia Hospital. Five, lecture by Dr. Helvan Safi'i Harahap, neurology specialist and neurodegenerative disease subspecialist consultant. Then discussion and closing. So, ladies and gentlemen, let's open this webinar ceremony with reciting basmalah. Bismillahirrahmanirrahim.
Bismillahirrahmanirrahim.
Next agenda will be welcoming speech. Allow us to invite Dr. Rohadi to deliver your welcome remark. Please welcome, Doctor. The audio is yours.
Thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good day, everyone, and welcome to this seminar on colorectal and liver cancer. Today marks another valuable session in what highly informative and dense series of discussion has been. Over the past seminar, we have already explored many critical aspects of update in medical knowledge, and I hope we will be able to hold sessions like this more frequently and irregular manner by inviting experts from all around the globe. I'm really excited to have you all here with us as we'll dive into this important topic. Colorectal and liver cancer continue to pose a significant challenge worldwide, and it is essential that we keep learning and improving how we diagnostic and treatment this condition. We are very fortunate to have with us today some incredible speaker who will share their expertise and experience. Dr. Paul Gobardan, MD, PhD, an expert oncology surgeon in gastrointestinal and colorectal surgery from Ampia Ziekenhuis Hospital, Netherlands, who will who will give us an update on the latest treatment and management strategy for colorectal and liver cancer, helping us understand what's new and effective. Next, we have Dr. Arif Zuhan, subspecialist bedah digestif or renowned digestive surgeon from West Nusa Tenggara Province Hospital, who will talk about his clinical experience in managing colorectal and liver cancer in West Nusa Tenggara, offering us valuable insight from a local perspective. And also, we have Profesor Dr. Herpan Salvi Harahap, Spesialis Neurologi, Subspesialis NGD Konsulta, Master Biomedic. We will focus of the neurological effect of colorectal cancer, who management manage them, and in another crucial layer to our understanding the cancer care. Today's session is a great opportunity to learn, ask questions, and share our own experience so we can all become better at treating this complex disease. I encourage everyone to engage fully in discussion with our speaker. Before we go, on behalf of University of Mataram and our partner, I want to thank you all for being here today. It's talk even likes this that we can come together to share knowledge, learn, from each other and ultimately improve the care we provide to our patients. With that said, let's process with today's presentation. I hope you find the talk both insight and inspiring. Thank you, and let's get started. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Doctor, for your delightful speech. Well, before we process to the main session, let me introduce our moderator for today's event, Dr. Tommy Irmayanto, a general surgery specialist. Here, his CV, Dr. Tommy is a surgeon who has extensive experience in his field and will be guiding us through today's discussion. Dr. Tommy was graduate from Medical Faculty of Mataram University. Then he was finished his surgery residency at Gajah Mada University, Yogyakarta. Nowadays, he is a lecturer at Medical Faculty of Mataram University and as a surgeon in Nusa Tenggara Barat Province Hospital. We hope this event runs smoothly under his guidance. And so, allow me to invite Dr. Tommy Irmayanto. The screen is yours, Doctor.
Yeah. Thank you for the introductions. Good evening, everyone, and good morning to Dr. Paul. I am Dr. Tommy Irmayanto and feel very honored to be the moderator of this event organized by Mataram University and Ampia Hospital, Netherlands. With the topic of colorectal and liver cancer, this webinar will discuss various important aspects of colorectal and liver cancer, which are one of the major concerns in the medicine today. We have three outstanding speakers who will share their knowledge and experience with all of us. The first speakers will be Dr. Arif Zuhan, spesialis bedah, subspesialis bedah digestif, konsultan, and he is a digestive surgeon. And the second speaker will be Dr. Paul Goberden, medical doctor, PhD. He is an oncology surgeon in gastrointestinal. And the third speaker will be Dr. Herpan Safii Harhab, specialist neurology, subspecialist neurodegenerative consultant, Magister of Biomedis. And I'm going to our first speaker, Dr. Arif Zuhan, subspecialist bedah digestive consultant. I will read his profile first. Dr. Arif Zuhan was born on Jepara on 1 June 1976. His pursue medical education in Medical Faculty of Muhammadiyah Yogyakarta University, and he pursued his specialist in surgical program Medical Faculty of Gajah Mada University in 2005 until 2010. And his pursue his subspecialty in digestive surgery program in Medical Faculty of Diponegoro University in Semarang 2016 until 2018. And now he is a lecturer in Medical Faculty of Mataram University, and he was Secretary of Surgery Department in Medical Faculty of Mataram University from 2010 and until 2016. He was treasurer of PABI, West Nusa Tenggara, from 2010 until 2016. And now he was attend Asia Pacific Digestive Weeks in Shanghai, China in 2016. He was attend a comprehensive laparoscopic surgery course in Mumbai, India in 2018. And now he is a subdivision of digestive surgery department, medical faculty in General Hospital of West Nusa Tenggara. He is head of general surgery specialist program in Medical Faculty of Mataram University. He was attend laparoscopic colon surgery masterclass in Manila, Philippines in 2023, and he was attend laparoscopic digestive surgery in Onomichi Hospital, Hiroshima, Japan in 2023. Dr. Arif Zuhan will present a topic about characterizing colorectal cancer, clinical experience from West Nusa Tenggara Barat Province General Hospital. I would like to ask Dr. Arif Zuhan for his time and screen. You have 30 minutes to present your topic. So please, the screen is yours, Doctor.
Thank you, Dr. Tommy Irmayanto, as a moderator today. Good morning, Dr. Paul Gobardan. Good morning, Dr. Chai. Nice to meet you, even in online here. And good afternoon, all of surgery department staff and resident in Faculty Medicine University Mataram, and all of medical student Faculty of Medicine, and everyone who attend in our webinar here. Assalamualaikum warahmatullahi wabarakatuh. Welcome to my presentation. First of all, let me thank you all for your coming here today. And let me start by saying a few words about my own background. My name is Arif Zuhan, and I'm a in Department of Digestive Surgery. And Honorable for Vice of Dean, Faculty of Medicine, Dr. Rohadi in Brussels now, and all the honorable for all speakers, especially for Dr. Paul Gobardan in Amphia Hospital, and the Professor Dr. Irfan Harhab. My presentation now is about characterizing colorectal cancer patient from my clinical experience in West Nusa Tenggara Province General Hospital. So we know from data of Globogan from 2018, the colorectal cancer is the third rank of disease, and in Indonesia is the fourth position rank from the total of cancer cases in Indonesia. And in our province, in West Nusa Tenggara, colorectal cancer is in the top 10 of disease from all of disease in our province. So let me, because this is the lecture for student too, let me explain about anatomy of colon. The large intestine extend from the ileocecal valve to the anus and is divided anatomically and functionally into the colon, rectum, and anal canal. The colon is begin in the junction of terminal ileum and the cecum and extend approximately 150 centimeters. And the rectal sigmoid junction is found approximately the level of the sacral promontory. So the cecum here is the widest diameter portion. The colon normally 2.5 or to 8.5 centimeters and has the thinnest muscular wall So the results, the second is most vulnerable to perforation and is vulnerable to obstruction. About etiology of colorectal cancer, from the genetic majority to from familial adenomatous polyposis (FAP). It's caused by mutation in APC gene, and individually with FAP develop numerous polyps in the colon and rectum during their teenage years, which can lead to colorectal cancer if untreated. And the other is Lynch syndrome, as we know, HNPCC, hereditary non-polyposis colorectal cancer. This condition is linked to mutation in mismatch repair MMR genes such as MLH1, MSH2, MSH6, PMS2, and it increases the risk of colorectal cancer and other cancer, often occurring in younger age. And the other etiology and risk factor is environment and other disease like red meat and processed product we eat can increase about 20% in risk, and meat consumption 100 grams a day can increase 17% for risk of CRC. And consumption of processed food about 50 grams a day can increase 18% for risk factor of CRC. The other diseases like colorectal can become carcinoma, 19 to 40% in 2 years, and adenoma can increase risk more than 40% if the size is more than 3 centimeters. And Crohn's disease can increase risk to 3 to 5%. And colitis ulcerative can increase the colorectal cancer if more than 20 years. And all globally with risk factor from diabetes mellitus, from family history of cancer, obesity, sedentary life, consumption of red meat, cigarette and alcohol consumption, and the age more than 50, 50 years old. Pathophysiology, the carcinoma from normal epithelium, and then mutation may cause activation of oncogen like KRAS, and the inactivation of tumor suppressor like APC related in BCC and P53. Colorectal carcinoma is the development from adenomatous polyps by accumulation of this mutation in what has come to be known as adenoma carcinoma sequence. The manifestation, clinical manifestation. You see the sign and symptom here: abdominal discomfort and change of full habit, bloody stool, and maybe accompanied by mucus, anemia, weight loss, and presence of abdominal mass. But the majority is bloody stool, 36%. This clinical sign of right side colorectal cancer and left side, as we know. And the specific examination like laboratory and radiology is there are many uh, examination like FOBT, fecal occult blood test, colonoscopy, the examination of tumor marker like CA, and radiology like barium and abdominal CT scan. FOBT detects hidden blood in the stool, which can be an early sign of CRC, and it's commonly used in screening program. And the next is colonoscopy, the primary method for direct visualization of the colon and rectum. And we can allow with biopsy with suspicious isolation and polyp removal. So it's both can diagnosis and therapy. And then the CT scan of the abdomen and pelvis to evaluate the extent of disease in the colon and rectum and identify metastasis, particularly in the liver and lymph nodes. And barium NM like this, like in the picture, is historically been used in the diagnosis and evaluation of the colorectal cancer, but its role has diminished with advance in other imaging techniques. This one is stadium for NCCN 2023. And the prognostic of colorectal cancer from stadium 1, 2, 3, and 4. More stadium, so the 5-year survival rate is more less. And this is the characteristics from our hospital for colorectal cancer patients. We do in 3 years, and we have 150 patients. And the result is the age of distribution colorectal cancer patient. Most colorectal cancer in the age range 46 and 55 years old. So the most cases of colorectal cancer are born at the age of 40 to 60 years. And the diagnosis of progressive colorectal cancer increase at the age of 40 years old. And increase sharply after 50 years, and more than 90% of cases occur over the age of 60 years. And we got the data, the male patient was higher than females, but 56% than 44%. The distribution of the location of colorectal cancer patient is the most in the rectum, and rectosigmoid is the most. And then follow a colon descendant and ascending colon. So the class is transverse colon. The surgical procedure we perform, Miles procedure, because majority to the case is in the distal of rectum. So we perform Miles in 30%. Ular is 3%. Low anterior resection is 16%. So sigmoidectomy and hemicolectomy is higher than sigmoidectomy, 25%. The data of grading well differentiated is majority 70%, then moderate differentiated, and the last is poor differentiated. The stadium of the patient, the patient come to the hospital majority in stadium 3 and 4, nil in stadium 1, and stadium 2 and only less and 3%. In West Nusa Tenggara, we have many ethnicity, so we can data for in ethnic Bali, Bima, Sumbawa, and Sasak, and the most is Sasak ethnic, 58%, and the less is for ethnic Bali, 4.2%. Other examination like CEA and distal internal stadium and interleukin 33, we perform too. The CEA mean is 17.24, and distal intramural spread is 0.92 centimeters. And then we examination interleukin 32 to 33 to make a research. This is our research about the extent of distal intramural spread of colorectal cancer cell in patient after neoadjuvant chemotherapy. Relationship with interleukin 33, histological grading and stadium, and CEA level. We know the margin distal resection is varies about among researchers. Some researcher is less than 1 centimeter, and some researcher more than 1 centimeter resection. And in Indonesia, the recommendation of distal resection limit has been revised several times from 5 centimeter to 2 centimeter. So it's based on the study of colorectal cancer in Indonesia 2016. This is my research about distal intramural spread of the tumor cells. This is the margin of tumor, and this is spread. And we measure the distal resection, and this is the proximal. This is the data like before. And our result is the grading and distal intramural spread. This is the correlation statistically significant. The P is less than 0.00. relationship of stadium and distal intramural spirit. There were a significant difference. The distal intramural spirit and CEA also make a significant correlation. The P is 0.024. So the conclusion of my research, the range of distal intramural spirit of colorectal sample is 1.07 and 11.4 the 9 millimeters, and longer of distal intramural spirit, creating histology worsen, tumor stage increase, and the higher CA level. Strongest correlation between distal intramural spirit and histological grading. Thus, in mid and lower third of the rectal cancer, the histology grading examination is strongly recommended. And we recommended that in rectal cancer undergoing sphincter preserving surgery, distal resection should be more than 2 centimeters from the tumor origin. And some experiential case of the patient, female 69 years old with obstructive ileus due to submucoid tumor, colon tumor. This one. And this is the specimen of tumor. The other case, this is the ileus obstructive due to tumor of transverse, and this is the specimen of tumor. Okay, thank you all of you for your kind attention, and nice to meet you. And we hope to meet in other chance and other time. Thank you for attention. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Arif Zuhan, for your very informative presentations. First, I want to welcome Professor Bert Van Giel, Professor Hamsu Kardian, and Dr. Che from Indonesian Diaspora Global Network Health. Thank you to attend this meeting. And we will proceed to the second speaker. Our second speaker will be Dr. Paul Gobarden, medical doctor PhD. He is an oncologic surgeon in Ampia Hospital, Netherlands. First, I will read his profile first. Dr. Paul Gobarden was born in Dutch in 3 October 1975. He was pursued his medical education in medicine in University of Utrecht, Netherlands, and then he pursued his natural science in the University of Utrecht, Netherlands, and graduation pre-university college, Sonsbeek College at Arnhem in Netherlands. And now he is a board member medical staff Ampia Hospital, Breda in Netherlands. And he is a staff surgeon, breast, colon, liver in Ampia Hospital, Breda in the Netherlands. He was a fellow, attend a fellow minimal invasive hepatobiliary surgery in L Institute Mutualiste de Montsouris, and then he was He is a fellow gastrointestinal and oncology surgery in Ampia Hospital in Breda in Netherlands. He was a surgical resident in Ampia Hospital, Breda, the Netherlands. And he was a surgical resident in University Medical Center Utrecht in the Netherlands. And then he was a surgical resident in Diakonen Swiss Utrecht in the Netherlands. Dr. Paul will present a topic about update management of colorectal and liver cancer. I would like to ask Dr. Paul Gobarden for his time and screen. Dr. Paul, are you with me?
Yes, I'm with you, Dr. Tomi Mayanto.
Okay. You have 40 minutes to present your topic. Please, the screen is yours, Doctor.
Thank you. Do you see my screen right now?
Yes, it's. I see it clear.
Okay. Thank you for your kind introduction. Good afternoon, everybody. And I'm very honored to be part of your scientific webinar this morning. I will give a small talk about the colorectal and liver surgery experience in the Netherlands, and especially in my hospital in Breda. For the people who hear this talk for the first time, the Netherlands, that's the country where I live in. It's a very small country in the northern western part of Europe. And my hospital is located in the south of the Netherlands. We, on the right side, you see on the picture my hospital, and it's one of the largest non-academic teaching hospitals of the Netherlands. Let's talk about some colorectal surgery. And Dr. Arif Souhan, thank you very much for sharing your experience. Also in the Netherlands, colorectal cancer is a problem, as it is in Indonesia, because it's in my country, it's the third most common cancer in prevalence in men, up to almost 13% of the cases. What is interesting to know is that in 2014, we started a national population screening for people between 55 and 75 years. And that's very interesting. In the data, Dr. Arif Souhan showed us that your patients are really young in your hospital. The patients in Netherlands are a little bit older, and I will show you in the next slides. That's why the population screening is for the targeted population of 55 and 75 years. We started in 2014 to collect stool samples and perform fecal immunochemical tests. And if that test was abnormal, then patients got an invitation for a colonoscopy. And what you can see in the graph is that the incidence of colorectal cancer is increasing till about 2015, and then it's decreasing. And that's because of the national population screening. So we detect people earlier. Of course, there's a small strange situation happened because of COVID-19, where the national screening program was delayed for a few months. I think it was about 6 to 12 months. Currently, the annual incidence of colorectal cancer patients in the Netherlands is about 12,000. These are the data of our screening program in 2020, where you can see that almost 1.3 million people participated in the screening program. That means that we have a participation rate of 61%, and the detection rate of a colorectal cancer of an advanced adenoma is 1.2%. So this is about 6 years after introduction of the screening program. But what we also see is that the participation rate of the screening program is decreasing. The blue lines are the purple lines are the people invited for the first round, and the blue lines are the people who were invited in the second round. So we see the participation rate is decreasing, and that's one of things we have to work on, to interest people to participate. Because what we see, if we look at the stage division in the past decade, we see that there is a decrease in the higher stage. So stage 3 is a little bit decreasing from 30% in 2012, so that was before the screening program, till about 26% in 2022. But stage 2 is decreasing more. And there's, of course, an increase in stage 1 disease, which is found during the colonoscopy. What I also find interesting, that in the talk of Dr. Arif, when he showed us your data, you have an incidence of 63% of stage 3 cancer. That's really high compared to the Dutch data. So this is the division between men and women. It's more or less equal, 50% in both. And as you can see, our patients are older, where your patients were in the group 45 to 70, where the highest peak is. The highest peak with us is after 60 years. So after 60, there's an increase in the incidence of colorectal cancer. For rectal cancer, it's the same, although it's a different entity, a little bit more men than women, 60% against 40%, but also increasing during age. And you already discussed why we should treat colorectal cancer. Of course, we should treat it to cure disease, but we also treat it to improve symptoms, to treat symptoms and improve quality of life. So in our Dutch guidelines, which is updated frequently, this is about the diagnostic pathway our patients undergo. Of course, anamnesis and physical examination, laboratory tests, of course, CEA levels, the colonoscopy, preferably with histology biopsy, and placing a tattooage for marking the lesion. We also perform a CT scan, not only from the abdomen, but also from the lungs, because about 20% of the patients do have synchronous metastases in lung and or liver. And in case of rectal cancer, we also perform an MRI of the pelvis. You discussed already the role of the colonoscopy in these type of patients. And for us, it's getting more and more important because of the histology biopsy and the molecular diagnosis we perform on the specimen. It's really helpful to know what we are looking for. The lesion can be marked, and of course, other abnormalities, other polyps can be removed. In case when there's an obstruction, a colonoscopy is not always possible. And what we do in my hospital is we do a completion colonoscopy after the resection, 2 to 3 months after the surgery. But there are also some hospitals who perform a CT colonography to check if there are other tumors in the rest of the colon. I want to talk to you about an institute we have in the Netherlands, which is called the DICA. DICA stands for Dutch Institute for Clinical Auditing. And it's a national audit now for more than a decade, which collects data for different diseases, not only about cancer data, but also vascular or trauma data. It gives the different hospitals, but also, of course, for my country, insight in the quality of care. And we see it as an instrument for learning and improving. And since the introduction of the audit, we see for colorectal cancer that mortality dropped from 6% in 2009 to 2% in 2022. Median hospital stay dropped from 8 days to 4 days, and the anastomach leakage percentage nowadays is 4%. And for rectal cancer, mortality even dropped from 4% to 1%, and the median hospital stay dropped from 10 days to 4 days. These are some old data, and I will promise you to give you the next time an updated version of these. But what we can see, and that's the reason why I wanted to show you, is that there is an increase in minimal invasive procedures. Laparoscopy for colorectal cancer started about at the end of the 90s in the Netherlands, and this increase continued. And during about 2015, 16, and I will show you later on the data of my hospital, we see the introduction of the robotic resections. So there's an increase in minimal invasive resection, laparoscopy, robot assisted, and we see a decrease in complications as anastomotic leakage. And accompanying, we see a decrease in hospital stay. And for rectal cancer, it's the same. We see an increase in minimal invasive procedures, especially for the robot, and a decrease in anastomach leakage. I wanted to show you this slide, which is over, I think, 20 years old. The ERAS protocol, and I'm not sure if you already used that in Indonesia, but what we try to do is to change as less on the patient as possible. So we don't use drains, we don't use catheters, we don't use anything like nasogastral tubes. We just want the patient to get out of their bed just as soon as possible after the surgery. But what we also do, and that's the movement currently in the Netherlands, is to start this optimization program before the surgery. And we call that prehabilitation. So patients are trained before the surgery. They go to the physiotherapist, they go to a dietitian, and they go to a stop smoking coach, because we all know that smoking is bad for surgery. Because I don't know how the minimal invasive situation is in your country, and I'm glad to visit you in 2 months, so maybe we can discuss it there. But just to take you with me 20 years ago. 20 years ago, laparoscopy in the Netherlands and Northwest Europe was a new technique, so they called it. And there were questions about what are the short-term risks and what are the long-term risks, and what about the costs, and what about the quality of life, and all that questions, of course, are answered in a lot of studies which are performed. And almost 20 years ago, there is a nice review in the Cochrane Library, which showed that laparoscopy in colorectal surgery, yes, it takes a little bit longer, but it gives less blood loss, it gives less pain, quicker recovery. There's no difference in morbidity, and patients stay shorter in our hospital. And on the long term, and that's mainly for oncology results, there's no difference between laparoscopy and open colorectal surgery. So nowadays, it's standard in Northwest Europe and especially in my country to perform minimal invasive surgery. I think more than 90% of our colorectal resections is performed or by laparoscopy or it is robot assisted. And in case of the robotic surgery, we now are talking and we are discussing the same problems which we did 20 years ago for laparoscopy. And I will promise you, in about 10 years, there's only robotic surgery in the Netherlands. This is our robotic ER. We have a Euro console, and two of my colleagues are trainers in the robotic surgery. We started in 2011 with the urology department, but soon we started in colorectal surgery. And as you see, we are the surgery, mainly colorectal surgery, is the green part of the graph. It's increasing, and we are performing more over than 200 colorectal procedures annually. And that's still increasing. Our second robot is coming in a few months. Because my colleagues started early and they're really early adapters, we are a case observation center. So from not only from Europe, but also from United States or Canada, people are visiting my hospital to perform to watch some of the series. This is just a small part about my interest. I'm really interested in single incision laparoscopic surgery. There are different names to perform it, but the goal is the same. All the laparoscopic instruments and the tissue extraction through the same incision. And I perform it most of the time through the umbilicus. And there are a lot of operations which can be performed single port. Actually, almost all laparoscopic procedures are possible. This is the port I use. It's a gel point, and it's from the company Applied Medical. It's a really easy, cheap port, and I just use normal instruments which are also used in laparoscopic surgery. This is what it looks like, and this is my personal experience with the single port procedures. For the most performed procedure is the right hemicolectomy, mainly for colonic cancer, but also for non-endoscopic removable polyps, neuroendocrine tumors, or benign disease. In my series, the mean operating time is about 100 minutes, with an endostomach leakage of 4.8% and a hospital stay of 3 days, and that's the medium one. Then a little bit about liver surgery. Liver surgery in the Netherlands is mostly performed for colorectal liver metastases. There are some, of course, primary liver tumors like the HCC or cholangiocarcinoma, gallbladder carcinoma. Those diagnoses are treated in my neighboring hospital, the Erasmus University. Liver surgery in my hospital is mainly for colorectal liver metastases, liver cysts complicated, or adenoma. As we showed before, colorectal cancer is the third most common cancer, and more than 30% of those patients develop synchronously or metachronously liver metastases, and only 32% of them have isolated colorectal liver metastases. And in the current literature, the local treatment, and that means surgical resection or ablation, is the only potential curative option. And besides these options, 75% will recur, of which 40% in the liver only. Most of the patients, unfortunately, do have unresectable colorectal liver metastases. So the resection we can only perform in case of when there's a possibility for radical resection. If we leave enough liver with a good function, we previously we kind of measured the function in the liver by volumetry, and we said, well, if we leave about 30%, then that should be enough. But since a few years, we use the functional scan, in which we measure the future remnant liver. And since we adopt that, there are no more cases of liver failure in our hospital. Of course, the condition of the patient should allow us to perform surgery. And between brackets, I said the absence of extrahepatic disease. When there's a limited extrahepatic disease, we just perform a resection and even combine it with metastasectomy from lung lesions or wherever the lesions are. Maybe you'll know that, but very short. Of course, there are some type of resections. We have the anatomical resections, the right and the left hemiapitectomy, even the extended version of that. We have the anatomical segment resections, for example, a left lateral sectionectomy, and we have the non-anatomical resections. About 10 years ago, the evolution in the Netherlands only started for laparoscopic liver surgery. And as Dr. Tomi Imayato read, I went to Paris in 2013 to work there with Professor Brice Gayet. He's one of the founders of the laparoscopic liver surgery, and he performed the laparoscopic liver surgery since 1995. So that's a very long time, and it almost took 20 years for the Netherlands to adopt that technique. I've watched him work, and we started our laparoscopic liver program in the Netherlands and in my hospital in about 2013 when I started working here, and that increases since that time. So you probably all know that the classic open liver surgery programs, which is used with a clamp crushing technique or finger fracture or just a knife, but there are some modern techniques. We first used in my hospital the hydrojet, but we started working with the ultrasonic dissection. There are some advocates for vascular stapling or Arava-based devices. But for the minimal invasive techniques, we actually use the ultrasonic dissection only. We use a stapler for dissecting portical pedicles or hepatic veins, but the dissection is performed using the Sonoka. In 2008, there was an international conference which stated that laparoscopic, this was the first consensus meeting with experts from all over the world, which stated that solitary lesions in easy accessible segments, so segments 2 till 6, should be standard of care for laparoscopic surgery. The posterior segments, so segment 1, 4A, 7, and 8, should be left for expert centers, including the major resections, and large lesions close to central vessels should not be performed in a laparoscopic or minimal invasive way. This was in 2008. And nowadays we perform actually almost all resections, excluding the one with portal vein reconstructions, but the rest of the resections we perform minimal invasive, or laparoscopically or by robotic assistance. This is old data, but it still works. Length of stay in laparoscopic surgery is less. There's less blood loss and there is less overall complications. Mortality rate favors laparoscopic surgery, and there is no difference in the recurrence in laparoscopic surgery. So that means that laparoscopic resection or minimal invasive resection is at least comparable, if not superior, to open hepatic resection. These are data from 2022, and my hospital is in red. And as you can see, nowadays we perform more than 80% of our procedures are performed laparoscopy, are performed minimal invasive. That means by laparoscopy or robotic assistance. What do you need for laparoscopic surgery? Of course, you have to know the liver. So experience in open liver surgery is useful. Know the anatomy of the liver, have the access to intraoperative ultrasound, and choose your instruments in which you like to work with. And if that's an harmonic ACE for ultrasonic dissections, or a QSAR or a Sanoka, that really doesn't matter. As I told you, over 65% of the patients have unresectable colorectal liver metastases. So if patients who are initially unresectable are able to be converted to surgery, then these patients might have a superior survival. So that's why a few years ago the Cairo 5 study was initiated, and this study randomized patients between a right or left-sided tumor between double or triplet chemotherapy. The conversion rate to resection was about 57 to 75%. And in patients with initially unresectable colorectal cancer, volvoxiri bevacizumab was the preferred treatment in patients with a right-sided RAS or BRAF mutated primary tumor. And in patients with a left-sided RAS and BRAF mutated wild-type tumor, the addition of panitumumab to Volvox or Volfiri showed no clinical benefit over bevacizumab. And of course, you can look up the results. This study is published. Another important study in which we are currently, which is currently ongoing, is the PUMP trial. And the PUMP trial has different types. This is the PUMP trial to investigate the recurrence rate in liver metastases. And the idea is that if we randomize patients after resection of the colorectal liver metastases to a standard arm, which means just follow-up, and an arm in which we place a pump so we can adjust arterial infusion, chemotherapy, maybe we can drop the rate of recurrence in liver metastases patients. And the chemotherapy which is used is fluoxuridine, which has a 95 first pass effect, which allows to give us 400 times higher concentration chemotherapy just in the liver. This is how this pump trial looks like. It starts chemotherapy after 4 to 6 weeks after the pump is placed in the arterial hepatic artery. Total of 6 rounds, so every round takes about 4 weeks, 2 weeks of fluoxuridine and 2 weeks nothing. The study is based on results from the Memorial Sloan Kettering Center in New York. And one of my colleagues from the Erasmus University, Bas Groot-Koerkamp, he introduced the pump trial in the Netherlands. And in their data, with a lot of patients, their median overall survival with high chemotherapy patients increased from 44 to 67 months. This is what I wanted to discuss with you in this meeting. I found it very interesting to see the data of Dr. Arif Suhan, and I think there is a lot of potential to discuss the differences between, for example, stage incidents, type of operations, but also, and maybe we can discuss it the next time, how to deal with obstructive colorectal cancer, because there's also a lot of discussion about that. Thank you very much.
Oh, thank you very much to
Thank
Dr.
you
Paul
very much,
Gomberden
Dr.
for
Paul.
a very insightful explanations. But first, before we going to discussion section, we will move to the third speaker. Our last speaker will be Dr. Herpan Sapi Harahap, spesialis neurologi, subspesialis neurodegenerative konsultan. He is a neurologist. I will read his profile first. Okay, Dr. Herpan Sapi Harahap was born in 24 March in 1975. He pursues his medical education in Medical Faculty of Brawijaya University and a Magister of Biomedicine in Brawijaya University also, and Specialist Neurology in Medical Faculty of Brawijaya University, and doctoral program in Medical Faculty of Hasanuddin University Makassar, and then a subspecialist program from Indonesian College of Neurology 2021. And now he is the chairman of Perdosni, the head of neurology specialist program in Medical Faculty of Mataram University. And he is a lecturer at Medical Faculty of Mataram University, the staff of neurology department in General Hospital of West Nusa Tenggara also. Okay, he will present a topic about neurological manifestations of brain metastasis of colorectal carcinoma. I would like to ask Dr. Herpan Safi'i Harhab for his time and screen. Dr. Herpan, are you with me?
Yes.
Okay,
Yes.
you have
Uh,
20 minutes to present your topic. Please, the screen is yours, Doctor.
okay. Are you seeing my slide, Dr.
Yes, I
Tommy?
see it clearly, Doctor.
Okay. Okay. Thank you for your nice introduction for me, and thank you for the time given to me to present my topics. We will talk about colorectal carcinoma in neurology perspective. My topic is neurological manifestation of brain metastasis from colorectal cancer. This is our outlines in this meeting. The first is important for colorectal carcinoma and epidemiology of brain metastasis from colorectal carcinoma, and then clinical characteristic of brain metastasis from colorectal carcinoma, and overall survival of the patients with brain metastasis from colorectal carcinoma, and then the prognostic factors and current treatment recommendation for brain metastasis from colorectal carcinoma. Uh, for the first, we know that colorectal cancer is the third most diagnosed malignancy and the second leading of cancer as a death. This data provided by Global Can in 2020. Uh, the typical presenting symptoms of colorectal carcinoma, as stated by Dr. Arif, include a change of bowel habits and rectal bleeding, and also abdominal mass. And some studies show that colorectal cancer present with iron deficiency anemia. Uh, Interestingly, even after complete resection of colorectal tumor, I think is it similar to other cancer that distant metastasis can be not still be not develop in about up to 15% of the patients. The most common site of metastasis from colorectal carcinoma are lung and liver and lung. And then brain metastasis itself is actually quite rare. But the prognosis of the brain metastasis in colorectal carcinoma provide very poor prognosis for the patients. I think this is the unique of the disease. And then how about the epidemiology of brain metastasis from colorectal carcinoma? I would like to show you about the recent study that so that brain metastases are not common even for the patient malignancy originating from the GI tract system, GI tract, and then hepatobiliary system and pancreas tumor. And then specifically for colorectal cancer, the incidence is quite low, less than 5%. Some studies show that this incident less than 1%. The typical patient with brain metastasis from colorectal cancer has a rectal primary tumor, a primary site, as shown by Dr. Arif. Most of patients with colorectal cancer in West Nusa Tenggara up to 72% from rectal sites. And then extracranial metastasis from the colorectal cancer commonly found is in the lung. And then metastatic disease of the brain in patients with colorectal cancer is associated with poor outcomes, as we stated earlier. Since the brain metastasis, since the patient with brain metastasis of colorectal cancer is associated with or preceded with other site of metastasis, especially in lung and liver, so we can consider that the brain metastasis occur at late stage of the disease. Most of colorectal cancer was found in first 2 years from the diagnosis of colorectal cancer itself. The brain metastasis is also considered as the result of increased survival, improved treatment options of the underlying disease, and better detection of even small metastases by magnetic resonance imaging. As we know that we just have information from Prof. Paul Gabadan how the treatment in Netherlands is so advanced. So maybe so I think it will increase the survival time for the patient with colorectal cancer. And maybe we need to consider that the incidence of brain metastasis of colorectal cancer will be increased. As brain metastases from colorectal cancer are rare, so there is lack of data regarding management with no guidelines for patients suffering from brain metastasis from colorectal cancer. Moreover, there seems to be a critical lack of information on presentation, treatment, and overall survival with regard to brain metastasis from colorectal cancer. Most recent study using small sample size for the participant, patient with colorectal cancer, and then using most of them also using a single center population setting. So most literature data show that brain metastasis from colorectal cancer is more common in males, who can account about 50 to 60% of case. We also just know from Dr. Arif that most of patient with colorectal cancer in West Nusa Tenggara is also male, about 65%, I think. The mean age of patient with brain metastasis with colorectal cancer is about in decade of 5 to 6. And then what about the clinical characteristics of brain metastasis from colorectal cancer? The majority of patients with brain metastasis are asymptomatic. They did not show any neurological symptom at the time of diagnosis. PRECOF so that 69 about 69% of brain metastasis patients were asymptomatic at the time of diagnosis, and this can lead to the late diagnosis and also make the prognosis more unfavorable for the patients. The use of screening program using cranial imaging for patients with colorectal cancer with risk factor for developing brain metastasis is encouraged. I think in West Nusa Tenggara, in population setting in West Nusa Tenggara, this is still difficult to screen routinely a patient with colorectal cancer with this cranial imaging, since this method is still not cost effective, and also the availability of cranial imaging in hospitals in our population is still not quite enough. This is the presentation from CT and from MRI in axial and also coronal section. Meta-analysis and systematic review by Muller showed that brain metastasis in colorectal cancer recommended MRI imaging of the brain if the patient had any neurological symptoms or risk factor for brain metastasis, such as the presence of lung metastasis, KRAS mutation, high CEA level, and rectal cancer. But I think it is still inconsistent with other finding from other study. Brain metastasis from colorectal cancer frequently found in supratentorial. So I think this is it can give it imply that most of the patient asymptomatic when the tumor located in infratentorial, for example, for in brainstem or maybe in cerebellum, so the clinical symptom would be detected earlier. As said earlier, that most of the patients with brain metastasis of colorectal cancer are asymptomatics. In those with neurological symptoms, if those with neurological symptom, the symptom most commonly found are headache, motor disorders, and memory disturbance, cerebral ataxia, epilepsy, vision disorders, nausea and vomiting, and focal nasal signs. Of course, this is it depends on the location of the tumor and then the number of the tumor. Among the symptoms, motor disturbance was the most common found, followed by headache and dizziness. And then, how about overall survival of the patient with brain metastasis from colorectal carcinoma? Overall, the prognosis for the patient with brain metastasis from colorectal cancer is generally regarded as poor. Okay, and the median survival time, according to Muller, is only a few months. If not treated, the patient will die in first 2 months. Okay, most of study showed that overall survival of the patient with brain metastasis from colorectal cancer within 2 to 9 months from the time of diagnosis. And then what are the prognostic factors of brain metastasis from colorectal cancer? Karnosky performance scale, the scale for the scoring system to evaluate the degree of functional impairment of the patient with cancer, and then the number of brain metastasis lesion, and then stage of primary tumor, and then the existence of distant lesion in extracranial at the time of diagnosis, and the modality of treatment for brain metastasis available were identified as independent prognostic factor. Okay, in meta-analysis by Muller, showed that cognitive performance scale score with more 70 and multimodal treatment, especially surgery and combined with radiotherapy, predict better survival. Several factors, including age, and then the increased level of CEA, and then multiple metastasis sites, other than brain, and then number of brain lesion and the presence of KRAS mutation were the predictors of overall survivor. The existence of KRAS mutation, maybe it is inconsistent because some studies show that RAS mutation is also associated with colorectal brain, the occurrence of brain metastasis of colorectal cancer. And then how about the current treatment recommendation? The current treatment recommendation from brain metastasis from colorectal cancer do not differ from other brain metastasis from other side. In treating brain metastasis, the objective is to palliate symptoms and to improve survival and quality of life. The most studies show that the modalities provided better survival rate for patients with brain metastasis from colorectal cancer are radiotherapy and surgery. Chemotherapy is considered as a poor modality treatment. This is because the blood-brain barrier blocks the passage of these drugs to enter the brain and eradicate the cancer. Therefore, until recently, the use of chemotherapy to treat brain metastasis resulting from any cancer is still unsatisfactory. Maybe it can be considered to use when we are combine this treatment with other modalities, such as surgery combined with radiotherapy and also chemotherapy. This is the reason why the chemotherapy cytotoxic chemotherapy did not satisfy in the treatment of brain metastasis of colorectal cancer, because even though blood-brain barrier is disrupted in brain metastasis from colorectal cancer, but the the uh, the increased permeability is still not enough for the drug to cross the surgery, radiotherapy, chemotherapy, and target therapy has been accepted for metastasis from colorectal cancer, including brain metastasis. Combined modality local therapy, including radiotherapy plus surgical resection, was associated with improved survival. Okay, this is from I think from Malaysia, that most suitable candidates for primary surgical treatment for brain metastasis of colorectal cancer are patients with a single supratentorial brain metastasis from colorectal cancer that is possible to be resected radically, and then patient with cognitive performance scale 70 or more, and then patient with no evidence of neurological deficit, and also patient with controlled other side metastasis. I think this is my presentation. Thank you. I hope it will useful for the students. Thank you.
Thank you, Dr. Herman Sati, for very interesting presentations. So there are some issues that we have as the outline here. First, the case of colorectal cancers is quite loud, both in Netherlands and Indonesia. There are differences in distribution. The age of the patient with colorectal cancer, where in Indonesian is younger in age, and advanced stage when it's diagnosed with colorectal cancer, and the increase of minimal invasive surgery, decrease surgical complications, and also the increase of screening modalities can increase the prognosis, I think. And the brain metastasis is quite rare, but the prognosis is poor. And then the manifestation is asymptomatic at the early stage, so they came in the late stage. So now we are entering the discussion session. For participant who wants to ask questions, please use chat features, or you can raise your hand virtually. We will select some questions to be answered by the speakers.
Please, all of audience, ask to ask, especially to Dr. Paul from
There are some questions.
Netherlands.
There are some questions from the audience. Maybe Muhammad Duta, you can turn on your microphone and ask your question.
The voice is Muhammad Duta. Your voice is not here.
Sorry, is my voice clear?
Yes.
Okay, thank you. Thank you for the time, Dr. Mayanto. So my name is Vita. I'm from medical student from the Mataram University. So my question is for Dr. Arif Zuhan. So what are the clinical implication of distal intramural spread of the colorectal cancer cells, and how does it influence the treatment decisions in rectal cancer management? I think that's my question. Thank you for that time.
Dr. Arif Zuharan, please, you can give your answer.
Directly, Dr. Tommy, not for one termin or. Okay, I will ask. I will answer directly. Thank you for the student Muhammad Duta. It's about the clinical implication of the spreading of tumor cells from colorectal cancer, and this make an influence treatment and make a treatment decision in rectal management. So distal intramural spread of colorectal cancer can have significantly clinical implication for the management of rectal cancer, affecting both staging and the treatment decision. Then the spreading of cell tumor, like distal internal spread, may indicate the more advanced stage of the disease. And the patient with intramural spread generally have a worse prognosis. More longer the spread, so the prognosis is relatively is worse. So those compared to those without the the longer. If it is associated with a higher risk of local recurrence and distant metastasis. So the treatment of and decision to presence of the distal intramural spread often warrants to the use of neoadjuvant chemotherapy. Chemotherapy or radiotherapy is useful for the downsizing and local tumor. It's aimed to reduce the tumor size and limit local spread and improve the surgical outcome. So the intramural spread influence surgical decision, including the extent of resection. If the resection is radically and clearly, so post-operative adjuvant chemotherapy may be recommended based on the extent of intramural spread. This is my opinion to your question. Maybe Dr. Paul Kubardan, any comment to this question? Please. Thank you. Back to moderator, Dr. Tom.
Okay. Maybe any comment from Dr. Paul before we move to another question?
Yeah, as Dr. Arif mentioned, the pre-treatment of rectal cancer, radiotherapy, sometimes combined with chemotherapy, is not only to reduce tumor size and prevent surgical problems, but also to reduce the local recurrence rate. And that's what's mainly what it's for. And in the Netherlands and Northwestern Europe, there are currently a lot of studies ongoing. So maybe that's not a topic for next time, because rectal cancer is really different than colon cancer. There are a lot of good results for the combination of radiotherapy and sometimes with chemotherapy. So nowadays, we in a selected patient group, we don't even perform a surgery. It's a watch and wait strategy, and sometimes so organ preservation is relevant, of course, in these group of patients. And as Dr. Arif showed us, that your mouse procedure in 38%, that's big surgery. And I think in my hospital, we only, for the rectal cancer patients, I think only in 10% of the cases we perform a abdominal perineal resection. So it's a very nice topic to discuss in future.
Thank you, Dr. Paul, for
Yes,
the
thank you.
answer. For Muhammad Duta, did you get the answer or any comment?
Yes, I think the answer is very clear and the explanation.
Okay.
I think that's enough.
So we
Thank you,
move
Dr.
to the next questions. To Lalu Sakti please open your mic and you can ask your questions.
Okay, thank you, Dr. Tommy. Is it clear, my sound?
Yes, it's clear.
Okay, thank you. Before I ask, so I have a lot of questions to Dr. Paul Groban. Maybe 7 questions here, but I think I cannot ask all of them. Maybe you can give me some limitation how many questions that I have to ask to Dr. Paul. Maybe 3. Can I
We
ask
can
3
try to.
questions?
Sorry, Dr. Paul.
If the moderator is okay.
3, okay. 3 also okay.
Okay, thank you. Thank you, Dr. Tommy and Dr. Paul. So I have 3 questions. So my first question was, Dr. Paul said that before that, it is very good screening at Netherlands. So the patient that, the colorectal patient that found earlier, so the prognosis was good. I think that's it. So what tool for the screening that you use at Netherlands? Is it CEA, marker tumor, or colonoscopy, or both of them? Maybe can you explain that to us? That is the first question, and this.
Shall I ask the first question immediately? What we use is the facial immunochemical test, so the FIT test. So patients get an envelope at their home just by normal mail. They give a stool, send it back to the lab, and only when there are abnormal results, patients are invited for a colonoscopy. So it's a features test.
Feces test. Okay.
Yes.
Okay. Thank you, sir. So I think it's clear. Feces test. Okay. Okay. Thank you. So for the second question was, you mentioned at your slide about the completion colonoscopy after resection. I think it's not common in our country for that. So can you explain to us what does that mean? When do you perform that completion colonoscopy? Maybe a few weeks after definitive treatment, definitive surgery, or like what?
For example, an obstructive colorectal problem left-sided, you can imagine that a preoperative colonoscopy of the complete colon is not possible. So for example, the case Dr. Arif showed us with an obstruction in the sigmoid, it's not possible to take a look at the complete colon before surgery. So what we do is we do the resection, and 2 to 3 months after the resection, we take a look at the rest of the colon. Okay, so but there is a possibility for a CT colonography, which inflates some gas from the rectal side, and then you can make a 3D visualization of the colon. But the problem is there's no possibility for histological examination, and small polyps, which can be the first, which can be early stage cancers, can be missed.
Okay. Okay, so the colonoscopy was the best option for completion,
Yes.
the radicality that we have, that we aim. It's like that.
Yeah, just perform the colonoscopy 2 to 3 months after resection. Or if you see something strange during the surgery, perform the colonoscopy on your OR.
Okay, thank you, Dr. Paul. And I think this is my last question. about the radiation at the rectal cancer. In my country, in our country, there is radiation that we know that short-term radiation or long-term radiation. Maybe there is a pre-resection radiation or after resection radiation. And you didn't mention about the radiation therapy at your slide. Do you perform radiation at your country too? Maybe please explain that to us.
Yes, but we use radiation or chemoradiation, as I just mentioned. I didn't use it in my presentation because rectal cancer is a different. Sorry, my lights. Rectal cancer is a complete different entity than colon in case of by means of treatment. So what we do is that there are three types: straight resection, preoperative radiotherapy, short course, or chemoradiation. But there's no radiation afterwards.
Oh,
Okay, but maybe that's a topic for the next time. It's nice to discuss even with the new insights in rectal cancer.
okay. Thank you.
Thank you
Thank you,
very
Dr.
much
Paul.
for the answer, Dr.
Uh,
Paul. I think it's very clear.
excuse me, Dr. Paul.
Okay, please,
How
Dr.
about
Arif.
the colorectal cancer with liver metastasis with radiotherapy? This is recommended or not?
Sorry, you asked if colorectal cancer with synchronous liver metastases, if you
Yes.
use radiotherapy.
Yes.
Yeah, what we do most of the time is during waiting time, we do the liver resection. So then we treat both organs in a short period. So first the radiotherapy on the rectum, then the liver metastases, and then the rectal surgery. But there are different strategies. There's also a strategy which says, no, just start with chemotherapy, perform a liver resection, and only give toxicity on the rectum if you are for sure that you can take it out, when there's no progression in metastatic disease.
Okay, thank you. Thank you.
Thank you, Dr. Arif. Thank you, Dr. Paul. So we move to the next questions, maybe from Dini Suryani. You can turn on your microphone and ask your question.
Thank you, Dr. Tommy. Thank you to all the presenter for the very informative presentation regarding colorectal cancer. I'm Dunu Sirani from Neurology Education Program. I want to ask about brain metastasis in colorectal cancer. And my question to Dr. Herpan Shafi Harhab. In the previous presentation, it was explained that the brain metastasis usually appear in stage 3 or advanced stage of after diagnosis of colorectal cancer. So when do we think or suspect that there are brain metastasis in this case, colorectal carcinoma, and when should we do brain imaging in this case? Thank you.
Okay. Okay.
Okay.
May I ask? May I answer this question, Dr.
Yes, please, Dr. Herpan.
Okay, thank you. I think it's difficult to be answered. Okay, it depends on the population setting. In our population setting in West Nusa Tenggara, it's not easy to perform imaging to screen the colorectal cancer routinely. Principally that sooner better, sooner diagnosed for colorectal cancer, so it's better to screen the existence of brain metastasis for colorectal cancer. But this is not always suitable for us. The availability of the MRI or maybe CT scan is not always uh, uh, always be found in hospital in our population setting. So maybe we can use imaging wise be wise with the patient with that showing neurological symptoms, including maybe the decrease of their functional functional ability. Uh, Maybe this is the maybe this the answer for your question.
Thank you for your explanation, Dr. Herman.
Thank you, Dr. Herman. So we move to the next questions.
May I question to Dr. Arif and Prof. Paul?
Oh, of course. Please,
Okay,
Dr. Herman.
because it's interesting that the Dr. Paul had explained that the advance of treatment for colorectal cancer is there the modality that you mentioned in your presentation is suitable regardless the existence of brain metastasis or not, maybe Professor. And then how about the prognosis? How about the prognosis of the patient with brain metastasis of colorectal cancer in Netherlands, maybe? Thank you. And then for Dr. Arif, maybe in the future we need to evaluate together patient with colorectal cancer for identify the existence of the brain metastasis of colorectal cancer maybe. Thank you.
Yeah, thank you, Dr. Herman. Maybe we first we going to Dr. Paul. You can
Yes,
answer
Dr.
the
Herpen, thank you for your question. Yeah, but I completely agree with what you presented. First of all, brain metastases are very rare, and actually, the strategy is the same in my country. We only look for it when there are symptoms. So, in asymptomatic patients, we don't screen them for brain metastases. And if there are brain metastases, we try to cure symptoms and improve quality of life. So that sometimes means doing nothing, and sometimes it means, for example, gamma knife radiotherapy, which is available throughout my country. But that's probably what we can offer those patients. I think that most of the patients with brain metastases should have metastases on different other sites. So that's probably not isolated metastatic disease. But unfortunately, the treatment options are very, very limited.
Yes, I agree with.
Thank you, Dr. Paul. So maybe Dr. Arif, you can answer the question.
Yes, I agree to Dr. Paul because in my experience from 2010 uh, until now, it is very limited the incidence of colorectal cancer with brain metastasis. And since 2010, I just only one patient. I found only just one patient with brain metastasis and on other metastasis too, to lung metastasis, to liver metastasis. So we uh, decision to palliative treatment with this patient. And I agree with you, with Dr. Herpan, to evaluate and more screening patient, especially for patient post-resection to evaluation about the metastatic to brain, and other organ. Thank you.
Thank you.
Thank you very much, Dr. Arif Duhan. And we move to the next questions. Maybe Dr. Rospi, you can turn on your microphone and ask your question.
Thank you, doctor. Uh, Good evening, everyone. My name is Rosvi. I am the resident general surgery. My question is to Dr. Paul. Dr. Paul. So, we see that in colorectal surgery, especially when there is an resection anastomosis, the diet timing is still be a resident dilemma. So, like, should I start at day 3 or not? Should I start right now or or tomorrow? But I see in your presentation slide that the length of patient care is 3 days, especially in ERAS. So my question is, when is oral diet given in resection anastomosis in Netherlands, uh, and especially in ERAS also? And is that any difference that timing of oral nutrition we start based on tumor site and or on the surgery, is that laparoscopy or open resection anastomosis? Thank you.
Thank you for the question. Dr. Paul, please, you can answer the question.
Yeah, Rosvi, thank you for your question. That's an interesting topic. When I started working as a staff surgeon more than 10 years ago, I had some colleagues which were a little bit older than me, and their patients could only eat after 3 to 5 days. Nowadays, when I when I do a surgery in the morning, when I come back at the end of the morning or in the early afternoon, they are already eating. Bowel preparation we do not use, because what we know, and that's part of the ERAS program, if you should change as less as possible to the patients. So just give them to eat. The anastomosis won't bother from the function of the bowel. So that's the philosophy in my country and in northwestern countries. Just start eating.
Okay, doctor. That's why the length of patient is about just only 3 days after the surgery.
What I didn't mention is that the data about the dates is changing rapidly. I think in the last year, in a neighbor hospital, they started to discharge their patients at day 1. So operate on one day and discharge at the next day. And we're doing the same in my hospital. Not it doesn't work always, but in a lot of patients, day 1 or day 2 is possible. But it's only possible if you preparate the patients on your outpatient clinic, and not only your patient, but also the nurse and the physiotherapy or anyone who is working on that patient. We have to tell them that it's okay to leave at day 1 or day 2, and it's possible.
Okay, I see. Thank you, doctor.
Okay. Sorry, Dr. Paul. Allow me to confirm about the questions. So you start the oral nutrition with liquid or directly solid food?
Whatever the patient wants. But in my opinion, solid food is better, because in liquids they can swallow themselves. So just give them, of course, an acute patient with obstructive colorectal cancer is a different patient. I mean, this is for scheduled colorectal surgery. just give them a normal diet, whatever they like.
Okay, thank you, Dr. Paul. So we move to the next question, maybe from Ewaldo. You can open your mic and ask your question.
Thank you, Dr. Tommy. Uh, um, Thank you. I want to ask to the Dr. Paul. So from your slides, you said is from nowadays robotic surgery or laparoscopic surgery is more preferred than open technique in the patient with the colorectal cancer. I want to ask you about how if we find some patient with the obstruction due to colorectal cancer tumor, uh, can what do you prefer? Do you laparoscopic or do you open technique? Thank you.
Hello, Ewaldo. Thank you for your question. It's a very good question, and that's why I mentioned maybe next topic should be obstructive colorectal cancer, because what the background of your question is probably when there's a abdomen which is full of bowel, how can you perform a minimal invasive procedure? The problem also is that patients with an obstructive tumor are in a bad condition. So what you have to do is to improve their condition before surgery. So what we do is we try to decompress the colon and the small bowel by a nasogastric tube. If that's not working, we try to place a stent in the tumor, so there is a normal passageway, or we perform a colostomy to decompress the bowel and to start the period in which we can optimize the patient. So if normal food isn't working, we give them TPN, sorry. TPV is Dutch. We give them TPN. But, and we know, and maybe next time I can present our personal results, we know that if we optimize these patients, we significantly reduce the surgical complications, including the need of a colostomy. Maybe we can share it next time, because it's a big topic.
Thank you, Doctor.
Thank you, Dr. Paul. It's very interesting discussions, but we have a limited time here. Maybe I will give for one question more. Maybe Dr. Putu Deni Tanaya, you can turn on your microphone and ask your question.
Okay, thank you very much, Dr. Tommy. Good evening, all participants in this meeting. I want to ask Dr. Paul. Good evening, Dr. Paul. Good afternoon. I have one question for you, especially for this topic in colorectal and liver cancer. As we know, colorectal cancer and liver cancer is holistic disease. We can see with the treatment or how to education to our patient about the disease. So, what is your technique and what is your solution in your country for you give the best education to your patient, especially for the motivation to your patient for the colorectal cancer patient to make a good prognosis for your patient. Can I know about your strategy in your treatment? Can I? Thank you very much.
And Thank you for your question. And what do you mean? Do you mean in pre-operative counseling, or do you mean for the period after surgery?
Pre-operative and after-operative condition for your patient. Thank you.
It's really it's a little bit a personal question, because I think everybody has his own way of counseling his patients. But I think that positivity always works. So, and I hope there are not too many oncologists online, but because surgeons are mostly more positive than oncologists. So I try to tell my patients that we have a possibility to cure them, and the cure is surgery. And if you counsel them very well, and we have different ways of counseling. We have group sessions, we have sessions with a nurse, we have sessions with a doctor, we have online, it's actually, I think it's too much in the way we counsel them. But the more questions you take away with the patients, and the more confidence they go to the theater, I think you will see how much and how fast they recover, and it pays out to counsel them really, really well, and take time for that.
Thank you, Dr. Paul. Dr. Denny, did you get the answer or any comment?
I get the point, Dr. Tommy. Thank you very much, Dr. Paul and Dr. Tommy.
Very much. Okay, we have come to the end of the program. Thank you to our wonderful speakers for the precious knowledge that has been shared today. I'm so glad to be the moderator in the events today, and I'm looking forward for the next collaboration, maybe Dr. Paul. And thank you to all our participants who have participated in this webinar with great enthusiasm. Hopeful that has been what has been conveyed today is useful, that can be applied in our daily practice. And see you in the next time. I apologize or if there are any shortcoming during this event. And the rest of the event will be guided by Master of Ceremony. Thank you very much.
Thank you very
so
much.
much. Thank you so much, Dr. Tommy, for bringing these lectures and discussion. And thank you for all the doctor that knowledge that both of you share today. But before we close this webinar, allow me to screenshot all the participants. So please give me your best smile. And for the host, prepare for the screenshot the Zoom meeting. Okay. Give me your best smile. Okay. 1, 2, 3, 4, slide 1. Done. For slide 2. Slide 3. Slide 4. Oh, there is an 8th slide. Slide 5. 6. Slide 7. And last slide, slide 8. Okay, for the host of the Zoom, is that all the slide all already screenshot? Okay, all the slide is ready to screenshot. Then finally, we come to the end of today's agenda, and let us close the webinar by reciting Hamdalah. Alhamdulillah Alamin. Thank you for all the speakers today. And apologize if I have any mistakes. So we hope all of the students learned something today, and thank you so much for your attention. See you on the next occasion. Assalamualaikum warahmatullahi wabarakatuh. Have a good day, everyone.
Waalaikumsalam.
Waalaikumsalam.
Thank you,
Waalaikumsalam
Dr.
warahmatullahi
Paul,
wabarakatuh.
Thank you.
Dr. Arif. Yeah.
Thank you,
Thank
Dr. Paul.
you.
Nice to meet you. Dr. Chai,
Thank you, Dr. Paul.
to meet you. Dr. Panjil, nice to meet you. Oke, terima kasih semuanya. Terima kasih panitia.
Terima kasih, Dok.
Terima kasih Dr. Erpan.
Dr. Paul.
Thank you, Dr. Tommy. Tadi mau muter apa itu? Video.
Ada videonya tuh sebenarnya untuk webinar ini, Dok, tapi